Now into CD management in pulmonary embolism in the post-operative period. Here we will suspect it when the patient has chest pain. When the patient has chest pain, the first is to consider a myocardial infarction, so we will do a EKG, and if we have doubt, we can also ask for the enzymes. But also, if all this is negative, maybe the patient could have pulmonary embolism due to deep vein thrombosis. The risk factors include age greater than 40, a venous catheter on the femoral vein, prolonged immobilization, for example, fracture of the pelvis. If the patient has a venous injury, previous venous injury, this usually occurs on the second to third day, maybe with postoperative fever, but we should consider all the time. So here we are not going to do the Wells criterion or anything like that. We will directly do the CT spiral angiogram. This would be the gold standard with a large IV contrast. In those in which the contrast is contraindicated due to renal failure, for example, we can do the VQ scan. So if this is positive, then we will treat it with heparin. Depending if the patient is very hemodynamically unstable, we can do the treatment before the confirmation of the diagnosis, in which case we can also give the fibrinolytic, will be a plasminogen activator, but only in the extreme cases. Sometimes we do prophylaxis in patients that have moderate to high risk with 500 units per 8 to 12 hours of enoxaparin, or the like 8 milligrams or 50 milligrams in 24 hours, depending on which presentation of heparin we are using. And if we suspect thrombophlebitis, because that's also a thrombosis but of the superficial veins, then we need to change all the IV lines that the patient